clinically, what should we do about those patients that we have determined are high risk? What's the best way with respect to monitoring and potentially treating? Any thoughts on that, Marivi?
Well, I think that as smoldering is a heterogeneous disease with patients at a different risk of progression to myeloma, the management should be risk adapted. And I don't know if in the future, I don't know in 10 years' time or in 15 years' time, really the entity of smoldering will exist or not. Because low-risk smoldering myeloma, maybe they should be categorized as monoclonal gammopathy, and the follow-up has to be similar to patients with MGUS. Patients with high risk we can discuss, we can potentially treat, but it's true that in the middle we are going to have intermediate smoldering myeloma, in which I think that it would be a good idea to follow them at the beginning during the first year or during the first 2 years, every 4-6 months, just in order to see the pattern of evolution of the monoclonal component, in order to see how the patients are evolving. And if the disease is stable, so they can continue with follow-up just once per year. And the challenging situation is for the high-risk smoldering, because this patient can be potentially treated, and there are right now 2 phase 3 randomized trials showing a significant benefit in terms of progression-free survival, and one of them in terms of overall survival, just with lenalidomide or lenalidomide and dexamethasone. And the 2 phase 3 trials compared Lendex or Len alone with observation, and the hazard ratio for progression was similar in both studies. But it's true that we have to recognize that authorities have not approved yet any drug for smoldering. Why? This is not because the drugs were not effective, but because these studies have been conducted by cooperative groups, and these trials were not based, well, the objective was not to register any drug, just to investigate on the disease. So is this fair? Maybe this is not, and this is the reason why we can potentially treat high-risk smoldering myeloma patients, and I think that patients are going to get a significant benefit. And of course, under the Lendex platform or Len alone, well, we are going to see maybe results coming from trials that are currently ongoing, combining Lendex with carfilzomib, ilotuzumab, ixazomib, or why not the curative approach, in which the Spanish myeloma group is involved together with the International Myeloma Foundation. So a much more aggressive option of therapy, even including transplant if the patient is transplant eligible, with the curative approach. Are we going to reach this objective? Well, we don't know yet at this moment, and well, this is what I would say, that the most consolidated data are coming from lenalidomide alone or lenalidomide and dexamethasone.
Shaji, I thought it was really interesting. The group, I can say the audience seemed to split between those that thought we should take a curative approach and those that thought we should take, I guess you could call it a preventative approach, where you give a short-term kind of therapy. Yeah. Thoughts?
I think it's going to be the next kind of the dividing type of debate. Like, we always used to be debating about transplant versus not transplant, but this is going to be even more of a debate, I guess. I think it's, I think Marivi, you brought up a very important point about, we never were comfortable doing anything for these patients. And so the first hurdle to overcome was that, are we harming patients by treating them early? And now we have 2 trials suggesting that whether you believe in the benefit or not, at least we don't seem to be harming those patients, either in terms of the toxicities or in terms of their ability to get myeloma therapy subsequently. And everything points towards us potentially changing the natural history of the disease. So I think the first question of, is it reasonable to treat, has been answered. Now the big question is, how do we treat them? Do we treat them like myeloma, which is the kind of the more curative direction, or do we treat them like secondary prevention approach, which would be like using the lower dose, one drug type approach?
I mean, you can imagine in 10 years' time that we may actually not have a smoldering category. We may have actually decided
MGUS and myeloma.
Yeah, these are the patients we're going to treat, and these are the patients we're going to...
Absolutely. So it'll be myeloma and pre-myeloma, right?
Yeah.
I think the smoldering myeloma definition has really benefited us, because it always used to make the community or the treating physician at least think about it a little bit more seriously than just, if you had called it muggers, I worry that many of those patients may have just slipped through the net and not been observed closely.
One of the interesting talks, Marie-V, was from Jean-Paul Vermond, and it was an area I hadn't overly thought about, I guess, talking about those patients with different diseases that also happen to have monoclonal gammopathy. Do you like to expand on that a little bit? Your kind of
so
thoughts?
I think that the concept of monoclonal gammopathy, I would say, but of clinical significance are relevant because, well, I think that he said the patients have a small clone of plasma cells, but these small clones are really dangerous. And I think that physicians have to consider this situation because these patients can be misdiagnosed of monoclonal gammopathy of undetermined significance, and this is not correct at all because they have significance. What is the problem about the significance? That we can face with patients with skin abnormalities, peripheral neuropathy, even renal impairment, many abnormalities in which, the physician have to consider the possibility of establishing the relationship between the symptomatology and the small clone of plasma cells. And I think that if you are able to establish the link, you have to treat aggressively the small clone of plasma cells. And I think that this was his main message. If you are able to establish the link, please treat the small clone because the clone has to be destroyed.
Yeah, and I think it was very interesting because we've all had those complicated patients that have the renal disease, that have the small M component, and then but also have diabetes and hypertension, and you're in that position of trying to establish that link and determine whether those cells are important in the pathology of the disease. So, and as you say, there was the neuropathy cases, the skin cases, the cardiac cases. I mean, it really was a good discussion. So what would your take-home thoughts be from the meeting?
I think from the point of view of the precursor diseases, I think there is more clarity in terms of how we define these people and how to follow them, how to risk stratify them, and certainly I think we have kind of crossed that red line, so to speak, that at least a substantial proportion of the myeloma community feels safe treating these patients.
Marie-V, anything
Well,
to
I
add?
would like just to add a comment from the biological point of view. For me, it's interesting to see how most genetic abnormalities are already present on MGUS status. Because maybe in some cases these plasma cells needed to be an appropriate environment to be expanded and finally to convert into multiple myeloma. Whilst another possibility is that maybe some patients do not need not only the expansion of the tumor clone but other abnormalities. I think that this type of investigators are going to be really interesting also in order to define which patients could be potentially treated like myeloma and in which patients we can potentially plan a prevention into the progression to myeloma.
Yeah, no, it's one of the talks I failed to mention actually, wasn't it? Is one where we were talking about the immune environment and how, as you say, many of the genetic abnormalities are present there from the beginning, and it's actually the T cell clones and the macrophages which are potentially the problems. And much of this has been shown in mouse models at the moment, and it's how we now move forward and demonstrate it.
And I think the relevance particularly is that we may be able to do interventions which doesn't have the kind of toxicity we have with the current myeloma therapies.
Yeah, no, lovely. Well, thank you very much for your time and your excellent discussions. Thank you everybody for joining us at the workshop, and we look forward to seeing you soon.